Welcome back, Sean Allen here with the Gait Guys. We're going to talk about a case today discussing arm swing and altered loading responses. What is normal arm swing? Arm swing is something that's not talked about frequently enough in gait and gait analysis in our opinion. And it's something that we like to talk about because not only is there a physiologic and locomotor response, but it's driven by a neurologic patterning that we developed at a young age. We can see here in this picture that we've got the left leg forward, the right leg back, and we can see that the arm swing on those limbs are contralaterally oriented. We see two lines intersecting at the beginning in the form of an X. We see the right shoulder and left shoulders are on an oblique line upwards, and we see a line moving through the pelvic girdle from the left hip down through the right hip in an oblique line in the opposite direction, forming an X. This is what we call antiphasic motion through the pelvis and the shoulder girdles. Because of these antiphasic motions through the shoulder and pelvic girdles, we see opposite arm and leg swing. These were driven early on in the cross-crawl pattern when we were children and infants, developing some early neurologic responses to locomotion through crawling. They then moved and continued on into adulthood, into walking and running. And we use them regularly to our advantage in sporting events. These shoulder and pelvic girdles are normally supposed to be antiphasic, as we've said. And when you lose that antiphasic motion, in other words, as these two lines crossing in the middle, as we see in the diagram, become a little more parallel, in other words, the X becomes less of an X and more parallel line, we see a change in the mechanical nature, both neurologically and efficiency from a biomechanics standpoint. Things that can drive this are spine pain. With spine pain or increasing pain in the spine, we tend to want to reduce some of the torsion and compression through the spine, and we can do this by decreasing the antiphasic motion of the shoulder and pelvic girdles, and thus arm and leg swing. As we dampen this response, we dampen the compressive and torsive responses through the spine, and thus reducing pain. Problems in the lower limb can also affect this antiphasic motion. If you have a sprained ankle, a painful knee, a painful hip, the loading response on that leg not only is painful, but may be moderated through a time phase loading response. Because of this, you're going to affect the arm swing in the antiphasic motion from above. So a lower limb problem can change this antiphasic nature and make a corresponding response in the upper limb necessary in order to balance out the body. You can also see this from a top-down response. If you have a biceps problem, biceps tendonitis, rotator cuff problem, or frozen shoulder in which the range of motion in the upper limb is altered, we can also see an effect in the lower limb as well, throwing off this antiphasic nature. Let's look at a case. We have an athlete here, a triathlete patient of ours, who has left calf pain and right quadriceps pain and right low back pain. So in translation, we have a problem or painful scenario, in the left posterior compartment of the lower limb and in the right anterior compartment of the opposite limb. So we're getting both an anterior and posterior response symptomatically in this client in two different limbs. On our examination, we do functional movement screenings, neurologic patterning assessments, as well as detailed muscle evaluation to try and tie in the muscle coordination and muscle weaknesses into the pattern. It helps us make a diagnosis a little more cleanly. In this case, we saw tibialis anterior was weak on the left and long toe extensors. These are both anterior compartment muscles in the lower limb, and they will impair the ability to gain increased ankle dorsiflexion, or as we refer to as loss of ankle rocker. This is naturally going to then create a premature calf Achilles load and a premature heel rise in the gait phase, which is going to purchase them quicker onto the forefoot, which is going to probably shorten the time phase on that left side, creating an abrupt loading onto the right side. On assessment on the right side, we found some weaknesses in the internal abdominal oblique and transverse abdominis, and some weakness in the gluteus maximus, particularly the iliac and sacral divisions, as opposed to the coccygeal division. We also found some weakness of the right latissimus dorsi. The lat is a huge assister in posterior arm swing, so if we see weakness here, we can probably assume that we're going to see some altered in posterior right arm swing. We will look at the video shortly. We also saw some short right quadriceps and short right quadratus lumborum. So we saw something in the anterior side of the body that was short and something in the posterior side of the body. Well, this is a clinical syndrome that many of you may have seen before, and it's referred to as lower cross syndrome. And we can see in this diagram weak abdominals and weak gluteus maximus are on one end of the cross, and tight hip flexors, quadriceps, etc., and tight paraspinal muscles are on the other end of the cross. And when we get this, we see a functional pathology through the lumbopelvic stability. In this case, we need to be very aware that the syndrome is infrequently found to be symmetrical. In this case, with the tightness of his right hip flexors and quadricep muscle and tightness of his right paraspinals, as well as weakness of the abdominals and weak glute, his pelvis is being drawn forward on the right side, creating a counterclockwise pelvic distortion pattern. This is going to alter his hip extension motor pattern, obviously, and result in what looks like a leg length discrepancy or a resultant limp, which we will see in just a moment when we watch the case. Obviously, we're going to see altered arm and leg swing with this, and a change in the torsional spine load, which is something that's difficult to see, but something that can be seen on the examination table, but perhaps less so during the gait phase. So let's look at this case. Let's loop the video so that you can see it. We'll shut down the audio here so we're not disturbed. And so let's just watch his gait on a few cycles here. Right away, it should look like he's having problems on toeing off on the left side. It looks like he's almost stepping down into a ditch, a small ditch, mind you, on the right side. So it looks like he's stepping abruptly off the left and heavily and quickly onto the right side. It may help you to look at the line of his yellow shirt meeting his blue shorts. Kind of cue in on that and you'll be able to see the limp a little bit easier. It does look like that right hip drops a little bit more. So again, quick off of the left, premature heel rise, premature right or left foot departure onto the right side. Premature departure off one and quickly onto the other can create a loading response required by the quadriceps, and this is what has caused the shortness in his quadriceps. Let's look at arm swing for a moment. We had found that his right lat dorsi muscle was weak, which is a nice posterior swing muscle. It creates extension through the shoulder and internal rotation. And we're seeing in this case that arm swing is flawed. His right arm is swinging predominantly forward and his left arm is swinging predominantly backward. This meets up very nicely with the altered lower limb. And this is obviously a change in the antiphasic nature. And moving forward, you can see that right arm moving forward very nicely, but it really does not go behind his body. And the left side, we'll look one more time, really stays behind his body and doesn't move forward. This is a neurologic guarding response to some of the pathology that we're seeing. So we see a left ankle rocker, a dorsiflexion loss, premature left heel rise, heavy load into right quadriceps. Lumbar extension, you're not going to see that very much or very easily on the examination here, gait-wise, but on the table it was quite evident that his altered hip extension pattern was forcing him to extend through his lumbar spine, which was also enabled by his weak abdominals and tight quadriceps. So today's summary: an impairment in any joint or musculature in the lower limb can eventually present as a altered arm-leg swing phenomenon and change the antiphasic nature of the upper and lower girdles, both the shoulder and the pelvis, and thus the arm and leg swing. If you want to find more about our work, here's where you can find it. We're on the web at thegateguys.com. We are on a Tumblr, which is our thegateguys.tumblr.com, which is our blog, which will feed into our website. Facebook, which you can also link to through our website. Make sure you like us on the page, because we do have some feeds during the day on Facebook that you will not get anywhere else. And we're on Twitter as well if you like to see the short, tiny URLs. That's a quick way to find our work. And we're also on our YouTube channel. We are up to about 100 videos right now. Videos like this is maybe perhaps where you found us on YouTube, but we've got other videos there, teaching videos. So we hope to see you on our social media sites. We also have podcasts, continuing education, lectures, DVDs, daily news, and our feeds on our blog and Twitter pages. Thanks very much for your time today.